Appreciate coming here, and I always enjoy listening to you. An editorial comment, I think they do a great job at Duke VA. I think it's very important that patients who have neurosurgery on brain tumors go to a center of excellence that can do all the specialized neurosurgery. Okay, so these are my disclosures. So what are the symptoms of brain metastases? The symptoms of brain metastases can be headache, seizures, focal neurological changes, nausea, vomiting, or cognitive dysfunction. And as he mentioned, we think about brain mets all the time. Patients are living longer and longer, and we as medical oncologists get lots of MRIs of the brain, and we find lots of patients who have brain metastases. So how often does it happen? So more than 50% of all intracranial tumors in adults are brain metastases. Why do we have an increased incidence of brain metastases? Well, one of the reasons is MRI. So we have better detection, and also patients are living longer, so we're ordering MRIs. And maybe the brain is a sanctuary, and that some of our therapies are not getting through the blood-brain barrier, so our chemotherapies, which may be effective and keeping disease under control in the systemic circulation, are not getting into the brain. So brain metastases. Metastases are the most common adult intracranial tumor. More than 50% of all brain tumors are from metastases. In patients who have systemic malignancies, brain metastases occur between 10 to 30% of adults. So between 10 to 30% of adults are diagnosed while they're alive with brain metastases, and 6 to 10% of children. Okay. What about at autopsy? So at autopsy in lung cancer, 65% of patients with lung cancer have asymptomatic brain mets or didn't know about it. So only 16 to 20% of patients with lung cancer are diagnosed during their life with brain metastases, but a much higher percentage. Melanoma, 7% of patients with melanoma have brain metastases. 7 to 10% of renal cell carcinoma. In breast cancer, 5% of women breast cancer during their life are diagnosed with brain metastases, but at autopsy, 21%. Colorectal cancer, 1 to 2%. Colorectal cancer is another disease in which patients are living longer and longer. Several years ago or several decades ago, we almost never saw brain metastases from colorectal cancer. But now that our systemic therapy is doing better, patients are living longer and we're finding brain metastases from colorectal cancer. Okay. So what about HER2/neu? HER2/neu is just a fantastic advance in medicine. In the past, HER2/neu breast cancer was the worst breast cancer. And MD Anderson has now shown that HER2/neu cancer is the best breast cancer. So my pathologists used to put on their slides HER2/neu negative prognostic feature. Well, really, these days, it's a positive prognostic feature. Because untreated, HER2/neu breast cancer is bad. But with treatment, the results are so much better. And now it is the best breast cancer if you take treatment. But 35% of HER2/neu patients who have metastatic disease end up with brain metastases. And one of the big concerns is trastuzumab. Trastuzumab, or Herceptin, is a fantastic drug. It is a big molecule, and the concern is that it does not get into the brain. And that may be one of the reasons why there's an increased incidence of brain metastases, because the HER2/neu, the Herceptin, is very effective at killing the lung metastases, the liver metastases, but does not kill the brain metastases. It's a very big molecule and may not be able to penetrate the CNS. Okay. So what is vasogenic brain edema? So the blood-brain barrier is kind of a funny situation. So what does edema mean? Edema means that the blood-brain barrier is disrupted. So if the blood-brain barrier is disrupted and the fluid is getting outside, then that means maybe some of your chemotherapy can also go through. So cancer disrupts the blood-brain barrier. Okay? Vasogenic brain edema is accumulation of protein-rich fluid in the extracellular space. So things have gone through the blood-brain barrier outside. There's increased vascular endothelial growth factor, and there's gaps in the endothelium. So there are gaps in the endothelium of the blood-brain barrier, and therefore proteins can get through, but potentially small chemotherapy molecules could also get through the break in the blood-brain barrier. So steroids, or particularly dexamethasone, downregulates VEGF, and facilitates fluid passage back into the ventricular system. Okay. But the blood-brain barrier, particularly the intact blood-brain barrier, limits the entry of large molecules. And that's probably one of the themes of my talk today. There are large molecules and there are small molecules. In particular, the NIBs. So sorafenib, sunitinib, all these small molecules, they're called small molecules. The MABs, the monoclonal antibodies, are large molecules. So generally the large molecules, such as trastuzumab, is a big molecule, has hard time getting to the brain, or alatinib, these tyrosine kinase inhibitors. These are pills, but they're small molecules. They may have an easier time getting into the brain. Chemotherapy may reach the brain tumors, particularly if the blood-brain barrier is disrupted. So you can see on the CAT scan that if you have edema, that means the blood-brain barrier is disrupted, so maybe the chemotherapy, or particularly the small molecules, can get through. And steroids may potentially reestablish the blood-brain barrier by reducing peritumoral edema. The center of the tumor may have good penetration from disrupted brain barrier, but the periphery may be subtherapeutic. So there may be differences in the blood-brain barrier. In the center of the tumor, it may be disrupted, so the chemotherapy may get in there, but at the edge of the tumor, the blood-brain barrier may be still intact, so maybe the chemotherapy will not get into the edge of the tumor. Therefore, those patients may not get a good response if the edge of the tumor, the blood-brain barrier is not disrupted. So just because you have a brain metastasis, let's say in particular you have a patient who has HER2/neu positive breast cancer and that brain met, it does not mean that the chemotherapy didn't work in the brain. It may mean the chemotherapy did not get in. So the chemotherapy, the tumor may be sheltered from the chemotherapy. So with an intact blood-brain barrier, particularly the large molecules such as trastuzumab, may not get in to the cancer. Okay. So this is just a schematic of the blood-brain barrier. Particularly you have these tight junctions. So an intact blood-brain barrier, the chemotherapy, and particularly the large molecules such as trastuzumab, cannot get through the blood-brain barrier and attack the cancer. So how do you get around this problem of blood-brain barrier? So one of the ways you potentially could do it is put chemotherapy into the carotid artery directly, and that didn't work. You can also try agents. So there are a number of agents we've tried in the past that disrupt the blood-brain barrier and see if that helps, but that did not help also. Okay. So these are, I think he also mentioned these, the different prognostic categories, and the most important thing in almost every solid tumor is performance status. Okay. So category 1 is if they have good performance status, KPS over 70, age less than 65, controlled primary site, their median survival is 7 months. But if the KPS, performance status, is low, it's 2.3 months, and in between it's 4.2 months. So I totally agree with Cody that the most important prognostic feature is performance status. And also control of systemic disease. So if systemic disease is under reasonable control, then it's reasonable to try to fight the brain tumor. So what about giving chemotherapy to brain metastases? Do we have a lot of trials? And the answer is no. There are not a lot of controlled trials of patients who have brain metastases given chemotherapy. So there's no large trials, but it's reasonable. If somebody has a small asymptomatic brain metastasis, it is reasonable to try to give them chemotherapy first. Chemotherapy may be easier, you may be given chemotherapy for something else, and at times you may not want to do surgery or radiosurgery. Okay. So what about small cell lung cancer? As we know, small cell lung cancer, the incidence of brain metastasis is high, but also small cell lung cancer is very responsive to chemotherapy. The response rate to small cell lung cancer chemotherapy is very high. Unfortunately, the duration of response is not very high, but the response rate to small cell lung cancer chemotherapy is as high as 80%. Okay? So there's some data, not great studies, but if you look at the response of small cell, the brain metastases, and systemic, it's almost the same. So there is some data, and there's some small trials of giving chemotherapy to small cell to brain metastases without radiation therapy, and they've had some response. And I've done that a few times. Patients have small asymptomatic brain mets from small cell, and you can give them chemotherapy. Even in previously treated patients, you can try chemotherapy. Okay? When they've added radiation therapy to chemotherapy in small cell, it does not improve overall survival. Okay. So what about non-small cell lung cancer? So in non-small cell lung cancer, the response rate to chemotherapy is less. So it is less responsive. It's also less effective than whole brain radiation therapy. So on the average, I would say for non-small cell lung cancer, chemotherapy is less effective than a systemic disease, though there are some small response rates. So I think most people would not give chemotherapy for non-small cell. Okay. So what about the data? So the data, if you have somebody who has non-small cell lung cancer and they've had no prior chemotherapy, the response rate may be up to 30%, and the survival may be 8 months. They've tried temozolomide, and the reason we use temozolomide because it works for other brain tumors, and there's not much response. They've looked at patients with asymptomatic brain metastases from non-small cell, and there's equivalent survival. So you could do chemotherapy first, followed by radiation, or radiation followed by chemotherapy, and there's a more or less equivalent. And there does not appear to be any advantage to giving chemotherapy and radiation in non-small cell cancer. So say this again. In non-small cell lung cancer, brain metastases, particularly if you're asymptomatic, you could do chemo first, followed by radiation, or radiation followed by chemotherapy, and there's no advantage of giving chemotherapy and radiation therapy together. Okay. What about pemetrexate? Pemetrexate we use for non-squamous cell, and that does have some activity against brain metastases. So they tried patients, 39 patients, and they had partial responses in 38% and stable disease in 31%. So there's some activity of pemetrexate in non-small cell lung cancer. So these are tyrosine kinase inhibitors. The point we're also making is that tyrosine kinase inhibitors, there are lots and lots of these new drugs, and they're small. So they're small molecules. So what are erlotinib? Erlotinib is a very highly effective drug, particularly for a very small subtype of lung cancer. So it's effective if you have an adenocarcinoma and you have mutation in exon 19 or 21. So if you have that specific mutation, patients have up to an 80% response rate to erlotinib. And the progression-free survival with CNS metastases may be up to 15 months. So it looks like patients who have brain metastases with the EGFR mutation, that erlotinib may be effective. Okay. So what about HER2/neu? So trastuzumab may not be a very good drug to go to the brain, particularly since it's large. Okay. So there's a small molecule called lapatinib. Lapatinib is a HER1, HER2, or EGFR1, EGFR2 small molecule tyrosine kinase inhibitor. And with capecitabine, or Xeloda, there's a 32% partial response. So again, erlotinib, a small molecule, may be good for EGFR mutated lung cancer, and lapatinib may be useful for HER2/neu brain metastases. Okay. So what about another small molecule? Dorafimib is for melanoma, for BRAF mutated. And again, this small molecule has a 39% response rate. So the theme is, if you have a specific mutation and you have a small molecule, erlotinib, lapatinib, dorafimib, these are all NIBs, all tyrosine kinase, the response rate is almost the same in the brain as it is in the systemic circulation. So what about Lance Armstrong? So Lance Armstrong had